The next procedure to be discussed is transesophageal echocardiography. This technique has made a substantial impact on the echocardiographic field in the last 2 years. This slide shows the increasing impact of transesophageal echocardiography at the Mayo Clinic in the first 2 years of outpatient application. This slide shows the clinical applications of transesophageal echocardiography in the first 1,000 patients at the Mayo Clinic. The most frequent application was in the study of thromboembolism or masses in 28% of patients, prosthetic valve dysfunction in 17%, native valve dysfunction, particularly mitral regurgitation, in 16%, endocarditis and its complications in 11%, thoracic aortic pathology, particularly aortic dissection, in 7%, critically ill patients, particularly in the coronary care unit and emergency room, 7% of patients, and congenital heart disease makes up approximately 5% of patients. This is a typical echocardiographic endoscopic transducer. The elements are mounted at the tip of the transducer. There are knobs which allow movement of the scope tip and transducer. The electronics exit through the handle. The actual scope is approximately 100 centimeters in length, 9 millimeters in diameter, and is marked in centimeter markings. The typical tip is approximately 11 millimeters in diameter. The shaft about 9 millimeters in diameter. This is a typical adult-sized endoscope. This is a monoplane scope, imaging in a single horizontal plane. This is a biplane transducer with a horizontal plane distally and a longitudinal plane mounted more proximally on the scope tip. Both monoplane and biplane will be discussed. Terminology of scope movement include advancement, withdrawal, and advancement of the scope, which allows superior and inferior structures to be visualized. The scope can be rotated to image medial or lateral structures in the horizontal plane, flexed anteriorly or anteflexion, flexed posteriorly or postroflexion, medial flexion, and lateral flexion. Each movement allows the transesophageal transducer to image different portions of the heart. All 4 movements are possible with each commercially available instrument. In the horizontal imaging plane, typically the plane is rotated for medial and lateral imaging, anterior flexed for more basal structures, and retroflexed to image more four-chamber or frontal views. In the longitudinal plane, rotation images lateral and medial structures. Lateral and medial flexion image short or long axis views of the heart. Anteflexion and postroflexion allow superior and inferior structures to be imaged. This is a typical transesophageal echocardiographic exam room. The table should be height adjustable for ease of the examiner. The echocardiographic instrument is at the head of the table to the patient's left. At the head of the table is an automated blood pressure recording device, suction, and pulse oximeter for monitoring patient's saturation. The assistant sits at the head of the table, monitoring patient and assisting during the exam. Drugs are variably used during the transesophageal examination. In our own experience, 100% received local pharyngeal anesthetic, 98% received an anticholinergic for drying agent, 70% received mild general sedation, 15% subacute bacterial endocarditis prophylaxis. Training of the transesophageal echocardiographic physician can be broken into two parts. The first, esophageal intubation. We suggest 30 or more intubations under the tutelage of a gastroenterologist, experienced transesophageal physician, or for intraoperative studies, an anesthesiologist. The second component of training is learning tomographic anatomy. For the inexperienced, basic echocardiography takes 6 to 12 months. For transesophageal anatomy, we refer you to literature and experience, usually 30 to 50 transesophageal exams. This segment illustrates esophageal intubation in the outpatient environment. The patient is rotated to the left in a decubitus position. Comfort is obtained, both warmth as well as a supporting pillow behind the patient. Usually the upper leg is positioned anterior to the lower to assure that the patient remains in the decubitus position. A minor securing restraint assures the patient will stay in the left decubitus position. Local pharyngeal anesthetic is administered in the form of an aerosol. Usually 1 or 2 applications are necessary. The patient is instructed to roll the anesthetic in the throat and then swallow. If drying or sedation is utilized, it is given through an indwelling antecubital venous entry site. We also use this site for contrast echocardiography, which has been illustrated earlier in this tape series. In this particular patient, we used approximately 2.5 milligrams of midazolam. The patient is sedate but cooperative. The scope tip is lubricated with KY jelly. The technique illustrated in this examination is a digital entry technique. The left index finger is inserted to the back of the tongue. The scope is placed beneath the index finger and then forced downward, having the patient swallow once. The scope usually slips into the esophagus without appreciable resistance. A bite guard is then placed between the teeth to protect the electronics of the endoscope. The assistant monitors the patient, assisting him with breathing, suction if necessary. The examination takes approximately 15 minutes. This allows for appropriate basal, four-chamber, transgastric, and aortic views to be obtained. Presently, approximately 1% of patients do not tolerate esophageal intubation in our echocardiography laboratory. A gastroenterologist can be helpful in these circumstances. At the termination of the examination, the scope is washed and cleaned of adherent material and then sterilized with a glutaraldehyde solution. The transesophageal examination usually begins with basal short axis and frontal four-chamber views. The scope is advanced into the esophagus approximately 25 centimeters. In the horizontal plane with progressive anteflexion of the transducer, short axis views are obtained, also by slight withdrawal, views of the pulmonary artery. With retroflexion of the scope, frontal four-chamber views are obtained. Advancement of the scope assists in these views. This is an anatomic specimen cut in the basal short axis view. The esophagus is located posteriorly. Immediately adjacent, the descending thoracic aorta. The esophagus is in immediate contact to the left atrial cavity. The most central structure is the aorta and aortic valve cusps. To To the right of the image is a pulmonary valve, the left atrial appendage, and the left upper pulmonary vein. To the image left is the right upper pulmonary vein. The transverse sinus is posterior to the aorta and exiting from the left coronary cusp, the left coronary artery. To the left of the image is the right atrial appendage, and more superiorly, the superior vena cava. This is a transesophageal echocardiogram of a basal short-axis view. The transducer is adjacent to the left atrial cavity. The central structure is the aortic valve, which is usually cut obliquely. To the right of the image is the pulmonary valve. A portion of the left coronary artery is visualized, the left atrial appendage, the left atrial cavity, and lastly, the left upper pulmonary vein. This segment illustrates a potential pitfall. Posterior to the pulmonary artery and aorta is the transverse sinus, a pericardial reflection. Occasionally, the tip of the atrial appendage appears as a tumor-like structure or ovoid structure. This is actually the normal left atrial appendage caught in short axis within the transverse sinus. This is an anatomic specimen cut in the frontal four-chamber view. The esophagus is posterior and immediately adjacent to the descending thoracic aorta. Next is the left atrium. The pulmonary veins are visualized posteriorly. The orifice of the mitral valve, the anterior papillary muscle, the ventricular septum, right ventricular cavity, right atrium, and in the floor of right atrium, the orifice of the inferior vena cava. The atrial septum separates the left atrium and right atrium. This is a transesophageal echo in the frontal four-chamber plane of view. The transducer is immediately adjacent to the left atrial cavity. The mitral valve orifice is best imaged in this plane of section. The left ventricle is visualized beneath the mitral valve leaflets. In a high percentage of normal patients, there is trivial mitral valve regurgitation as illustrated on this color flow image. With preferential visualization of the atrial septum, the right atrium, right ventricle, and tricuspid valve are visualized. The thin portion of the valve of the fossa vallis separates the fatty limbus of the atrial septum. Contrast echocardiography in this position opacifies the right atrium and subsequently right ventricle. Note that there is no contrast in the left-sided chambers. The next sequence illustrates the technique of imaging the pulmonary veins. Also note the large fatty annulus of the tricuspid valve, which is a normal variant and should not be confused with tumor. With anteflexion and withdrawal of the scope, the mitral valve and subsequently the left atrial appendage are visualized. Superior to the left atrial appendage is the left upper pulmonary vein. The plane of tissue which separates the left upper pulmonary vein and atrial appendage often has a bulbous appearance and should not be confused with tumor. Rotating the transducer rightward will demonstrate the right upper pulmonary vein. The scope is advanced to visualize the right lower pulmonary vein. Subsequent withdrawal and advancement will image upper and lower pulmonary vein. The scope is now being turned leftward to again image the left upper pulmonary vein. The next animation segment illustrates the technique of transgastric imaging from short and long axis projections. The scope is advanced to approximately 40 centimeters from the incisors, antiflexed into the fundus of the stomach. Short axis views can be obtained in a bread loafing fashion by progressive antiflexion and retroflexion. Longitudinal views can also be obtained from the transgastric position. This anatomic specimen is cut in the transgastric short axis view. It is viewed from apex toward base with the anterior wall to the top of the image, posterior wall to the bottom, left ventricle to the right, right ventricle to the left, and the right ventricular outflow tract anteriorly. In order to obtain this preferred anatomic orientation, the transducer artifact is imaged at the bottom of the screen. This is adjacent to the posterior wall of left ventricle. The posteromedial and anterolateral popliteal muscles are viewed from apex toward base. The ventricular septum and right ventricle are to the left of the image. The anterior wall is furthest from the transducer. This particular view is used to monitor left ventricular function during high-risk cardiac surgery. In the long axis projection or longitudinal view, the transducer is posterior to the posterior wall of left ventricle. The mitral apparatus and its support are visualized in long axis. The anterior wall and posterior wall are respectively visualized along with left atrial cavity. The next animation is that of the longitudinal views from the mid-esophageal transducer position. Biplane scopes are utilized. These are best appreciated as sagittal views imaged from the left. There's the left atrial view, the right ventricular outflow view, aortic view, and superior vena cava view. From the aortic view, long axis and short axis projections are obtained by lateral and medial flexion of the transducer. Going full lateral, the transducer can be carried off through the pulmonary veins to the descending thoracic aorta. On the right side of the heart, when the scan is carried off the heart, it images the right pulmonary veins. This specimen has been cut in the longitudinal view. As imaging from the left side of the heart, the esophagus is posterior to left atrium. The mitral valve is visualized in the superior portion of the left atrium. Left atrial cavity is visualized beneath the mitral valves. The anterior and posterior wall of left ventricle are respectively imaged. In the atrioventricular groove, the coronary sinus, anteriorly in the left atrial cavity, the left atrial appendage, and the left upper pulmonary vein. Anterior to the left upper pulmonary vein is the left pulmonary artery. These sections can be sequentially imaged from left to right in the heart. In the longitudinal plane, 4 basic views are obtained as illustrated on this composite image. First is the left atrial view, in which the left atrium is visualized adjacent to the transducer, anteriorly the left atrial appendage, the mitral valve, and left ventricle. By rotating the transducer rightward, the right ventricular outflow view is obtained. Transducer is adjacent to left atrium, and far anterior is the right ventricular outflow tract, pulmonary valve, and main pulmonary artery. An oblique section of the left ventricular outflow tract is visualized in between. Further rightward rotation visualizes the aortic view. The transducer is adjacent to left atrium, anteriorly are the aortic cusps, the ascending aorta, the left ventricular outflow tract, anterior leaflet of mitral valve, ventricular septum, and the right ventricular outflow tract. This is akin to a parasternal long axis view of the aorta. Still further rightward rotation results in the superior vena cava view. The transducer is adjacent to left atrium. The atrial septum separates right atrium from left atrium. Inferiorly is the inferior vena cava, which can be traced up to the superior vena cava in long axis. Anteriorly is the right atrial appendage. These are the 4 basic views obtained from the longitudinal projection from mid-esophagus. The next sequence illustrates these longitudinal views. First is the left atrial view, which left atrium is posterior, mitral valve, and left ventricle. The next view is the right ventricular outflow view, with the right ventricular outflow anteriorly cut in long axis, the main pulmonary artery, an oblique section of the left ventricular outflow tract. The left atrium is posterior, with further rightward rotation of the transducer. An oblique section of the ascending aorta is the primary structure. The ascending aorta is cut in long axis. Posteriorly is left atrium. The right pulmonary artery is cut in short axis, posterior to the ascending aorta. A portion of the atrial septum separates right and left atrium. The superior vena cava is the next view by progressive rightward rotation of the transducer. Superior vena cava in long axis goes through right atrium and can be projected down into the inferior vena cava. The sequence will be shown in real time. These progressive longitudinal views are obtained by rightward rotation of the transducer across the sagittal planes of the heart. The four basic views are obtained in sequence: left atrium, right ventricular outflow, aorta, and superior vena cava. The next sequence is a longitudinal scan in a patient with mitral stenosis and rheumatic heart disease. This is an extremely slow scan, scanning from left to right. In the lateral left atrial cavity, one can visualize the upper and lower pulmonary vein, and superiorly a portion of the distal left pulmonary artery. As the scan is rotated progressively rightward, the partition between atrial appendage and superior pulmonary vein are visualized. The left pulmonary artery is visualized superior to the atrial appendage. This progressively turns into the main pulmonary artery. The transducer posteriorly is adjacent to the left atrium. At the apex of left atrium is the mitral valve, which in this patient is stenotic. Below the mitral leaflets, left ventricle. The ventricular septum separates right and left ventricle and the right ventricular outflow tract. Further rotation results in the long axis of the ascending aorta. This is akin to a parasternal long axis view of the aorta. Posteriorly is the left atrium. Anteriorly, the long axis of the ascending aorta. As the transducer is slowly rotated rightward, portions of the superior vena cava come into view. The superior vena cava will be imaged in long axis and will enter the right atrial cavity. Notice portions of the tricuspid valve are visualized. Anteriorly, the right atrial appendage. The atrial septum separates left atrium from right atrium. Notice the valve of the fossa vallis in the mid portion of the atrial septum, with the superior fatty limbus of the atrial septum appearing as more hyperrefractile thickened portions of the septum. In the right atrial cavity is the eustachian valve, which appears as an undulating membrane. Superior to left atrium is the right pulmonary artery cut in short axis. As the transducer is rotated to the extreme portions of the right atrium, the superior pulmonary veins are visualized. To further illustrate this imaging sequence, the transducer will be rotated from right to left. This is the long axis superior vena cava view. The long axis superior vena cava, the distal right pulmonary artery superior to the left atrial cavity. With leftward rotation, the long axis of the ascending aorta, the distal portion of the right pulmonary artery are visualized posterior to the ascending aorta. As the scan is carried further leftward, the long axis of the right ventricular outflow tract is visualized, and yet further leftward rotation, the left atrial appendage, the partition between the upper pulmonary veins and atrial appendage, and the left pulmonary artery are visualized. The left upper and lower pulmonary veins are visualized with far leftward rotation. With rotation off the heart, the long axis of descending thoracic aorta is visualized. The next animated segment is the visualization of the thoracic aorta and the technique to image that structure. The thoracic aorta lies adjacent to the esophagus. By turning the transducer posteriorly and to the patient's left, the thoracic aorta can be imaged sequentially. The transducer can be advanced below the diaphragm. Withdrawal of the transducer results in sequential short-axis views of the aorta up through the ascending aorta and aortic arch. This can be repeated by advancing the transducer through the esophagus and imaging the thoracic aorta down into the stomach. Longitudinal views can also be obtained with the same maneuver. Sequential long-axis views of the descending thoracic aorta, aortic arch, and ascending aorta can be obtained with this maneuver. This is a transesophageal echo of the mid-thoracic aorta. The transducer is intimately adjacent to the aortic orifice. Posteriorly is the vertebral body. Note that the azygous vein lies just posterior to the aorta. Longitudinal views can be obtained with biplane transesophageal scopes. Color flow can assist in imaging the movement of blood within the thoracic aorta. The combined short and long axis views of the aorta greatly increase the diagnostic capability of this technology. The remainder of this videotape series deals with major unique applications of transesophageal echocardiography. The first application is the clinical assessment for source of embolism. The first example of thrombus is in a 64-year-old female with mitral stenosis. In this basal short-axis view, the superior vena cava, aorta, and pulmonary artery are visualized. Within the left atrium and the left atrial appendage are multiple thrombi. These could not be visualized by precordial echo. The next example of thrombus visualization is in a 74-year-old man presenting with clinical pulmonary embolism. The right atrial cavity is visualized, the tricuspid valve, and right ventricle. Within the right atrial cavity is an undulating, multifaceted mass consistent with peripheral embolization of thrombus. The thrombus was adherent to the eustachian valve and was captured in right atrium. On basal short-axis views of the aorta and pulmonary artery, progressive antiflexion of the transducer allowed imaging of the right main pulmonary artery. As this scan was carried to the patient's right, notice that there is a mass in the distal right pulmonary artery just posterior to the superior vena cava. Investigators have reported the utility of transesophageal echocardiography for the visualization of proximal large pulmonary emboli. The next example is that of spontaneous contrast effect in a 50-year-old female with mitral stenosis. In the basal short-axis view, the aorta, proximal left coronary artery, and atrial appendage are simultaneously visualized. Note in the apex of the left atrial appendage that there is visualization of blood or spontaneous cavitation effect. This is indicative of low output state or the sludging of blood and has a higher incidence of systemic embolization. The next unique application of transesophageal echocardiography is identification of the patent foramen ovale for source of embolism. This is a frontal four-chamber view with visualization of the left ventricular outflow tract, portions of the mitral valve, and the atrial septum. Note in the membranous portion of the atrial septum with color flow Doppler, there is turbulence within the valve of the fossa vallis. This is indicative of shunt through a patent foramen ovale. These patients are presumed to have a higher incidence of paradoxical embolism. Contrast echocardiography can also assist in the detection of right to left shunt. In the overall assessment of patients with source of embolism, the thoracic aorta should be assessed for atherosclerosis. This is an example of a patient with severe aortic atherosclerosis. Notice the nodular appearance to the mid-thoracic aorta. Many of these nodules appear to undulate on their surface, consistent with thrombus. Aortic ulcerations can be recognized by the transesophageal echocardiogram. More importantly, as the scan is taken toward the aortic arch in this particular patient, small endothelial excrescences or pedunculated masses will be visualized. Endothelial irregularities should be considered a potential source of embolism. Note as the scan is taken into the ascending aorta that a mobile pedunculated mass will be visualized. This atheromatous thrombus is considered a potential source of embolism. This is frequently observed in patients with severe atherosclerotic disease of the aorta. The next unique clinical application of transesophageal echocardiography is the assessment of the prosthetic valve, particularly the mitral prosthesis. The first example is that of a 62-year-old man with mitral prosthesis. and clinical deterioration. On the frontal four-chamber view, medial to the sewing ring of the prosthesis, there is a thin perivalvular regurgitant jet. As the scan is taken further laterally, the ball is seen within the cage prosthesis. There's a small, normal regurgitant jet or closing volume. With further lateral rotation of the transducer, a larger regurgitant jet is visualized. This large jet fills the left atrial cavity and washes back into the left upper pulmonary vein and is consistent with severe mitral regurgitation. The next example is that of a 72-year-old man with a mitral heterograft. The transthoracic examination is shown for comparison with the transesophageal echocardiogram, which will follow. Note that the left atrium is free of obvious echoes. The transesophageal echocardiogram was performed because of increasing Doppler velocities across the prosthesis, suggesting stenosis. On a transesophageal frontal four-chamber view, impressive amounts of thrombus are visualized in the left atrial cavity. These were missed by the transthoracic exam. Notice the relative immobilization of the heterographed cusps, consistent with stenosis. The next most frequent clinical application of transesophageal echocardiography is the assessment of native valve dysfunction, in particular mitral regurgitation and their causal pathology amenable to valve repair. This is an example of a 56-year-old female with mild mitral and tricuspid valve regurgitation. On a frontal four-chamber plane, the mitral valve leaflets appear somewhat thickened and myxoid. With color flow Doppler, there is a single central jet of mitral regurgitation which is assessed to be mild. The tricuspid valve also shows a small regurgitant jet. This is an example where biplane transesophageal echocardiography will be superior in the delineation of the degree of mitral regurgitation. Note that there are single jets in this horizontal scan. This is a sagittal view of the left atrium in the longitudinal plane. Left atrial appendage is anterior, mitral leaflets, and left ventricle are visualized. With color flow Doppler, there is an additional jet visualized, which exits the posterior mitral annulus and laminates along the posterior wall of left atrium. Complete imaging of the mitral valve is best accomplished with a biplane transducer in order to visualize multiple regurgitant jets. The next example is that of a 69-year-old female with clinically severe mitral regurgitation in whom the precordial echo could not adequately assess the degree of regurgitation. Note that the valve leaflets are thickened, the left atrium is markedly dilated, there's calcification in the mitral annulus, and there's a lack of coaptation of the posterior leaflet of mitral valve. With color flow Doppler, there is severe regurgitation of the valve. There are two jets, both coming from the posterior leaflet of mitral valve and totally opacifying the left atrial cavity. This is severe mitral valve regurgitation. This is an example of a patient being considered for mitral valve repair versus replacement. On transesophageal echocardiography, there is obvious prolapse of the posterior leaflet of mitral valve. The left atrium is only moderately increased in size. The left ventricle is hyperdynamic. Note that portions of the mitral valve support apparatus flail into the left atrial cavity. The posterior leaflet lacks coaptation with the anterior leaflet and should be associated with severe regurgitation. Note that the regurgitant jet laminates along the posterior wall of the aorta, consistent with a posterior mitral valve leaflet prolapse. This clinical picture is consistent with a valve suitable for mitral valve repair as opposed to replacement. This is the intraoperative echo of the same patient following repair of the prolapsing posterior leaflet. Notice that the leaflet has been plicated and that there is adequate coaptation from the anterior leaflet. Intraoperative transesophageal echocardiography assists in determining the adequacy of the mitral valve repair. With color flow Doppler, there is no regurgitation during systole. This is a diastolic frame showing the lack of opacification of left atrium, a very successful repair. This next example shows the utility of biplane transesophageal echocardiography in the assessment of aortic valve regurgitation. This is a frontal four-chamber view of the mitral valve, left ventricle, and left ventricular outflow tract. Notice that the aortic annulus is slightly dilated. With color flow Doppler, there is a regurgitant jet from the aortic valve which laminates along the undersurface of the anterior leaflet of mitral valve. This appears to be a moderate-sized regurgitant jet. This is a longitudinal imaging plane with a transducer adjacent to left atrium. The short axis of aortic cusps are visualized. Anteriorly, the right ventricular outflow tract. The left, right, and non-coronary cusps of the aorta are visualized in short axis. Note that the regurgitant jet occupies a small portion of the left ventricular outflow, consistent with mild aortic valve regurgitation. Biplane transesophageal is superior to moderate regurgitation.